present colostomy complications and how to deal with them, and just to be inclusive, and I thought I would just talk about stomas. So that will include both colostomies and ileostomies, as well as some of these principles will apply for the ureterostomies. So most of these principles will be the same. So what I'm going to talk about is going to be broken down into two portions. The first one is the surgical considerations. I'm going to focus on the thinking about how to construct the stoma. So the thinking from the time that we start thinking about doing the stoma into creating the stoma. And the reason I wanted to present that first is the more time you spend and the more careful you are preparing for your stoma, the less complications hopefully you'll have. The second part will be about the complications. So timing, what do I mean by timing? Timing is, so when we start thinking about doing a stoma, there are actually two phases. So we're either thinking about them pre-op. So for instance, we're talking about gynae oncology here. So if someone is presenting for a pelvic exenteration, that'll be the time that you're thinking about doing a stoma, a pre-op, and it's an elective procedure. Another pre-op time is when you have someone who presents with a trauma. So someone that presents with a trauma, say a pelvic trauma, and you as the surgeon taking the patient to the operating room, most likely you're thinking that you need to deal with, we're going to end up doing a colostomy or an ileostomy. The other part is something that is actually unforeseen. So you went into the operating room and you had a bad injury or something, a major complication happened, and it was not safe to put the bowel together. So then that's the intraoperative part of doing a stoma. I think the more you kind of foresee what issues you might have in the operating room, the better your informed consent are, and the more prepared you and the patient is for the stoma. So in the preoperative example that I mentioned, counseling of patients is very important. A lot of the literature does not talk about the psychological impact of stomas. And I think the psychological impact in our culture is even more magnified. People have difficulties. I've heard so many stories about people having difficulties going to the mosque, and it's just, for us socially, having a stoma is way more impactful than in the West. So counseling of patients is important. The great advantage of having a pre-op preparation is having the visit to the stoma therapist. I'm not sure if we have a stoma therapist here or not, but I think having a stoma therapist or a stoma nurse is very valuable to patients that might have colostomies. In the intraoperative part, again, what I mentioned here is if you anticipated that you might end up with a stoma, I think you should mention it to the patient. And that should be mentioned in the consent. Nothing would be more devastating for patients to end up with an unplanned or unforeseen colostomy. Again, especially in our culture. So the patient goes to the stoma therapist. With the stoma therapist, the ideal area to create a stoma. And again, these are forgive me for going over these basics, but some of the audience actually are juniors, so it's good to know this. So somewhere midway between the iliac crest and the umbilicus, through the rectus muscle, and usually it should be below the belt line. The bigger the belly of the patient, the higher the stoma should be. You don't want to put a stoma in the panas. If someone is morbidly obese, then you want to go above, and you might forego actually going for below the belt line. But these are the principles. So what does the stoma therapist do? They actually look at different positions and plan the stoma site accordingly. Again, some of these stomas are permanent. So if you have someone with inflammatory bowel disease and they're not going to end up having their stoma reversed, so this is a permanent stoma. So I think we should take all the time to prepare to have a very good, well-positioned stoma. So they do it lying, they do it sitting, bending, and standing to have a perfectly placed stoma for the patient. This is very important for the one that will end up having a permanent stoma. So that's one area that is important. The other area is, should we do a colostomy versus ileostomy? So the outcome measures, sorry, this slide kind of must have jumped here. Shouldn't be here. So the other surgical consideration is the outcome measures. So what do I mean by that? So there are things that will, by which you can evaluate how good or bad the stoma is. So there are measures during construction, there are measures during function, and there are measures at closure. So for instance, things we were interested in is the likelihood of necrosis, prolapse, retraction, hernia, stenosis, sepsis, and hemorrhage. Function, the likelihood of occlusion or peristoma, skin irritation, and closure measure again. This will, when you're mindful of this, then the way you close the stoma might differ. Whether you want to close it with a stapler or with hand sewn. But again, these are historical data that when the researchers go back and look at, basically judge the way that how we create stoma. So for construction, there is still controversy on whether or not actually going through the rectus muscle is associated with less hernia. I mean, that's the old teaching, but I think a lot of the studies did not prove that. But we still do it. I mean, for us, it's one of those surgical dogmas that we do. But again, the literature says it's not actually that big of a deal. So, colostomy or an ileostomy. So again, just some basic slides for the juniors. This is a slide of a colostomy, different areas of colostomies, and this is an endoileostomy. So just a quick look at the literature. These are different case series that compared both colostomy versus ileostomy for complications. So as you can see, there are only two prospective studies. The rest were basically retrospective, and most of them did not show any significant change. So, the first one is 164 patients, no significant change. The second one is more than 400. But what they found is colostomy is associated with more kind of a worse odor, whereas ileostomy, knowing the content of ileostomy, are liquidy associated more with leakage. And I will show you that leakage and having an ileostomy is associated with a higher risk of peristomal skin irritation. Again, this study did not show any significant difference, but the subset analysis shows more hernias with colostomies. But for the juniors, when you do a study and then you end up with a subset analysis, that does not, the study was not structured to look into to answer that question. So you can play with the numbers. You know, if you want to get, أقولهم بالعربي كده, ممكن تعصر numbers. You crunch the numbers different ways until you get the result that you want. But just from a statistical standpoint, this study did not show any significant difference. And the same for the other study. Now, these last two studies actually did show a difference. So 1,600 plus patients as stomas, and the loop ileostomies are associated with 75% complications, overall complications, which is interesting compared to end colostomy. But look at the year, it's 1999. So again, factor all that into the equation. You know, with time we get better at our techniques. So these are apples and oranges and watermelons and what have you. So, the point behind this table is just to tell you that there is controversy. So loop versus end. This is on the right-hand side. This is a loop ileostomy, and again, this is another cartoon of a loop ileostomy, and this is an end ileostomy. Loop, technically easier. What do I mean by technically easier is you probably would not need to do a big laparotomy to get the loop out. A great example is if you do a transverse colostomy, you can just make a small, tiny transverse incision in the upper abdomen, and you can get the transverse colon out that way. So that's what I mean by technically easier. So the formation and closure is easy, but sometimes pulling the stoma out may you know, in an obese patient may be a problem. The end in a permanent stoma, it's easier to exteriorize, and because you don't have the other loop to deal with, and you can get more length. Two studies looked at compared loop to. Again, there are more studies, but I'm selecting some studies for you. The first one in 2005, more than 300 patients, and the loop colostomy was associated with the highest complication rate, and the end ileostomy had the lowest. The second one showed that the stoma with the lowest complication rate was the end colostomy. So for fecal diversion, should we use loop versus end? This is a large meta-analysis that had 12 studies and more than 1,500 patients. And their conclusion was that patients with a loop ileostomy had a lower risk of prolapse and sepsis, but increased risk of occlusion after stoma closure and dehydration. Again, going back to the outcome measures. So you have measures at creation, you have measures for function, and you have measures for closure. That's another study. So this is a prospective randomized trial for fecal diversion in rectal cancer patients. 36 patients with loop transverse colostomy versus 34 patients with loop ileostomy. And the conclusion that there was no difference in difficulty of formation or closure. And no difference in postoperative recovery. But all the complications, what I mean by no difference, again, you're talking statistically significant difference, but they found 10 complications in the loop colostomy group. So they concluded, based on their understanding of their study, that the loop ileostomy is better for defunctioning, for low anastomosis. And again, this is practiced by a lot of colorectal and general surgeons to use the loop ileostomy for diversion. So now that's the second part, is the stoma complications. This is just to give you an idea of, again, for juniors, of what a healthy stoma looks like. It's nice and pink. If this is a live video, then you'll see that the bowel is moving and it's noisy, and so that's a healthy stoma. It's good to know what a healthy stoma looks like, so then you can tell what's abnormal. So now we're getting into not very nice pictures. So this is a peristomal hernia. Peristomal hernia, the literature is very confusing. The incidence can be all the way down as 3% and as high as 48% in some series. What they, out of all these studies, they found out that it's associated more with end stomas rather than loop stomas, and it's associated with loop colostomies versus ileostomies. What are the risk factors? I'm saying here that creating a stoma outside the rectus muscle, but you can see the exclamation mark, because actually this was our understanding, and this is the understanding of a lot of surgeons, but this does not, when you look critically at the literature, this does not pan out to be true. It's controversial. I was actually kind of surprised to find that this is not a big deal, but we don't have level 1 evidence yet. The size of the fascial opening, that makes sense. The bigger the size of the fascial opening, the more like the chance of having a hernia. And then the other issues that will just delay and interfere with the wound healing. If you want to think about, stomas, in my mind, and again, I think if you have a loop of bowel or a piece of bowel that is going through the fascia, at some point these patients will have a hernia, because it's different from having an incision that you closed. You have a defect, and you have something that moves within this defect. So this is my own anecdotal personal opinion. But looking at the literature, these are the incidences that I've given you, and I think the difference between the studies is the period of the follow-up period. So I think the longer you wait, the higher the incidence of peristomal hernias. So how do you treat it? The non-operative, again, it depends. Always, when you think about any of those complications, going back to the basics, are we dealing with a permanent stoma or a temporary stoma? So if we're dealing with a temporary stoma, always think, is it time to close the stoma so we can just get rid of all the issues? Can I cheat and actually just close it 2-3 weeks earlier? So always think that in temporary stomas. Now in permanent stomas it's different. In permanent stomas, then you're dealing with, can the patient actually tolerate a procedure or not, and then whether you deal with it locally or basically with a laparotomy. I think these are the principles, and this applies to all the complications that I'm going to mention. So we can do primary repair, we can do stoma relocation, or we can do mesh repair. And the suture repair has been shown to be inferior to mesh repair, or relocation of the stoma. Interesting, laparoscopic peristomal hernia is found to be safe and feasible, but there is no long-term data. Using biologic grafts is associated with less infections, and in some series, 0 infection, but it's more expensive. And another interesting idea, and you might want to think about this in patients with permanent stomas, is using a prophylactic mesh. But knowing how surgeons think, we're very hesitant to use mesh, especially non-biologic mesh, in a field where you have stoma. You basically have feces. But you can use the biologic mesh as a prophylactic. So that's always another option that you can use. If you're dealing with a weak fascia, and you think that this patient is going to get into trouble, and this is a permanent stoma, then that is an option that you can use. Again, one of those not very nice pictures. I've actually seen an 80-plus-year-old lady in my training with something very similar to this. So what do you use for this? What is it? We have two demonstrators. So this is a prolapse. So what do we use for prolapse? Sugar. So the incidence, ileostomy is 3%, colostomy is 2%, urostomy is 1%. And this is why I wanted to just to lump everything together, just to tell you that the principles are the same. You're having a loop of bowel and you're pushing it through the abdominal wall. So I think all the complications can happen to different kinds of stomas. So it's more with loop stomas and more with distal end rather than proximal end of the loop itself. The risk factors are pretty much the same. One thing extra is failure to fix the mesentery. Again, these are not level 1 evidence, but I just put this as one of the findings in one of those studies. Some studies say if you fix the stoma intraperitoneally versus extraperitoneally, the fixation point with the intraperitoneal is proximal, so you can have a tendency to prolapse more. So they're saying if you fix it intraperitoneal, and we all do that, then the chances are higher. But again, these are all not level 1 evidence. Treatment, conservative, so sugar. So have a lot of sugar in the emergency department. Actually, that lady that I treated ended up, that prolapse actually reduced. Now those, a very old patient who might not just stand a haircut, let alone surgery, maybe you just want to deal with the problem conservatively, or maybe just deal with it locally. But the other options are resection, revision, and relocation. And again, always think, can I just close the stoma in a temporary stoma? So high stoma, high ostomy output. It's good to just to get an idea about the normal physiology. So there are about an average of 10 liters, give or take, that get absorbed through the GI tract, from the stomach all the way down to the anus. So the proximal your stoma, the more chances of dehydration. I think the colon absorbs anywhere between 2 to 3 liters. And then just try to understand what electrolytes are absorbed in what portion of the intestine. Bile acids are very irritant to the skin, and bile acids are present in ileostomies, so they can give patients a lot of trouble. So high output stoma definition is controversial, but this is one of the magic numbers I found. Is more than 2 liters. It's more with jejunostomy rather than ileostomy. Again, the proximal, it's just very easy. The proximal, the stoma, the more fluid you will lose. And excessive stoma losses can give problems with dehydration, electrolyte abnormalities. And what are the causes? Extensive small bowel resection or just a proximal stoma. So that's just the principle. You can have short gut, or you can have functionally short gut when you bring up proximal stoma. Intrinsic bowel disease, like inflammatory bowel disease, partial small bowel obstruction, this is very common. So a lot of the high output stomas that we see in a kind of a full length small bowel is just partial small bowel obstruction. Give it some time post-op and it will go away. And then these are the other causes. So what are the metabolic effects? I've mentioned those. Why do these patients get renal stones? For 2 reasons. They're dehydrated. They lose a lot of fluid, and then their urine is acidic. So this is one of the late complications in chronic high ostomy output. They can get renal stones. So treatment, intravenous, you have to replace their fluid, you have to replace their electrolytes, you have to minimize their oral intake, and then the use of antidiarrheals like loperamide, use of antisecretory like H2 blockers and omeprazole. So skin irritation, this is the incidence. As I mentioned before, this happens more with liquidy stomas rather than formed stomas. So you're talking ileostomy, and they're irritant for 2 reasons. It's liquidy, and so it leaks, tends to leak, and the bile acid is very irritant to the skin. So when ill-fitting, you have to have good appliance, and this is the importance of intrastomal therapists. They're very important. You should have either a stoma therapist or a nurse that is interested in stoma to deal with those. Frequent appliance changes. Average, if you have a kind of a well-behaving stoma, you should not change the appliance more than once a week. Higher BMI and diabetes were found in one of those case series and multivariate analysis to be an independent risk factor for skin irritation. And then the stoma contents. So how to prevent these are the prevention measures and good stoma appliances. One of the things that one that understands stoma treatment can use is appliance with convexities. So this is an example where you have basically have a kind of a divot, and the stoma can leak a lot. So using a stoma appliance with a convexity will help protect that. So you use adhesive pads and you use a stoma with a convexity. That can minimize the risk. Plus, you want to try to minimize the output, and so a high ostomy output is a risk for skin irritation in itself. Stricture and stenosis, the major risk factor is ischemia. If it's mechanical, you're going to find out soon, but most of the time it's ischemia. This is an indication that you have issues with ischemia. How to deal with it. You want to make sure that if in someone with inflammatory bowel disease or cancer, that you're not dealing with cancer. Again, same principle. Is it a temporary or permanent temporary? You might want to just think about helping the patient with a bit of a dilation and then closing it. If it's permanent, then you have to deal with it accordingly, according to whether or not the patient can tolerate the procedure. Retraction. This is the incidence anywhere between 1 to 6% for colostomies and 3 to 17% for ileostomies. How to prevent them? Sufficient length of the bowel is needed, and just good surgical technique. Sometimes, whatever you do, the patient has a big abdominal wall, and they have a very fat and thick mesentery, and it's just sometimes you cannot. Whatever you do, you can't. So in summary, what I've discussed on my talk is preoperative planning is very important. I've mentioned the timing. Are you dealing with an elective procedure or with an emergency? And always use the stoma therapist and try to have a perfect sighting and planning of the position of the stoma. Counseling for patients, especially for our patients, is extremely important. This is something that is overlooked, and it's probably more troubling for patients, and I consider it as a complication compared to the hernias and the other stuff that we can fix, especially in patients that will live with their stomas. Parastoma hernia is very common, up to 48%. Mesh repair is superior to just tissue repair. Prolapse can give patients difficulties with the appliances, obstruction, and ischemia. High ostomy output, as I mentioned, will lead to dehydration and electrolyte abnormalities and vitamin deficiencies. Overall, for fecal divergent, loop ileostomy is superior, and inst stoma functions better than loop stomas. Thank you.